Okay. Thank you all for being here this morning and welcome to the LGBTQ plus health programs Pride Month talk with Dr. Seth Davis, who will be presenting on the order of operations in gender affirming facial surgery. I just have to say, I'll let Dr. Davis introduce himself more formally, but it has been such a pleasure to work with Dr. Davis since he's joined, and I've had a chance to see him present at one of our community engagement events. So I know that everyone here is in for a treat. I really appreciate, Dr. Davis, the way that you go through the history of kind of gender affirming facial surgery and why it's so important to our patients and our community. And so I'm so excited for everyone to get to hear from you personally, your anecdotes and your information, the historical piece, and then your expertise in this area. So without further ado, I will hand it off to you.
All right. Well, thank you so much, Blaze. This will be a very similar to what you've heard previously, but I'm excited to get to share it with all of my fellow colleagues here at Stanford. I'm gonna dive right in here and make sure that I can advance slides, and I'll give a quick introduction to myself as well. I have no disclosures to make outside of the fact that any photos and videos that are included in this talk are used with patient consent. So this is just a contact card for me. A couple of things that I'll point out. I'm an assistant professor in the Department of Otolaryngology, Head and Neck Surgery, and that's the first thing that I always have to clarify. I am a facial plastic and reconstructive surgeon, but I don't exist in the plastic surgery department. I do work closely with our colleagues in that department, but I'm part of the ENT or otolaryngology head and neck surgery department. And so if you're looking to find me, say within the system or on the internet, that's where you would see me. My email address is down here at the bottom. I'm happy to be in touch with any of you. Feel free to use it. And I'm also happy to give out my cell phone number to anyone who I might share patients with or is just interested in talking further. Very quickly about me. I come from the Midwest. I was actually born and raised in Wisconsin. I did most of my training there from an undergrad and a medical school standpoint. I then went on to train in ENT head and neck surgery at Vanderbilt, and then did my fellowship in Indianapolis at Indiana University, at really the only institution in the state that did provide gender affirming care. And so was very immersed in gender affirming facial surgical care while I was there, along with sort of the full breadth of what facial plastic surgery provides. And so just to highlight, and I won't go through all of this, but I do a broad spectrum of things in my practice, from functional surgeries to reconstructive trauma and cancer, all the way to cosmetic surgery, elective cosmetic surgery, and of course the special patient population that I'll be speaking about today are my gender affirming patients, and we'll dive in deeply to what that entails, and what all is available for patients here at Stanford. So starting from the very bottom, but what is gender affirming facial surgery? I think from a very sort of blanket perspective, this encompasses any surgical procedure that aims to modify facial features to be more congruent with desired physical expression of gender. And really the goal there is to reduce gender dysphoria. So any procedure involving the face aimed at reducing gender dysphoria falls into this category. You'll see a number of synonyms used throughout this and other presentations: facial gender surgery, facial gender confirmation surgery. One of the most common colloquialisms you'll see in our literature and perhaps out in the community is facial feminization surgery. And that tends to be because about 80% of the surgery that is sought out from a gender affirming facial surgical perspective is sought out to be facial feminization surgery versus facial masculinization surgery. And we'll talk a little bit about why that might be. So let's see here. So Douglas Oosterhout is sort of the pioneer in this field of gender-affirming facial surgery. He came from right here in our own backyard at the University of San Francisco, and he was really the first U.S. surgeon to describe the bony changes that can be accomplished with gender-affirming facial surgery that really transitioned surgery from a soft tissue rearrangement surgery to a bony craniofacial restructuring surgery that has really been able to allow us to gain the impact that we have and the dramatic results that you'll see throughout these presentations. And of course, his work has been carried on by a number of individuals across the country, and I'll highlight a lot of that work here to talk about sort of the collective and collaborative effort that has gone into trying to optimize surgical outcomes in a safe and effective manner. We're all familiar with ideally a lot of this preferred terminology. We know that using preferred terminology is empowering for individuals. And so this is obviously for a broad audience, but a number of common terms that you may see throughout this presentation are highlighted here. And I just wanted to sort of bring into the conversation this resource from Action Canada for Sexual Health and Rights. I think they do a great job highlighting some of the perhaps less commonly encountered terms. It's a great resource to go to make sure that you're using terminology appropriately, interpreting it correctly. They also have sexual terminology as well that they do a great job of highlighting. And so I found this to be a great resource because, of course, we're all imperfect and we all may misinterpret or misutilize terminology at times. As long as your intention is correct, we find that people appreciate the respect that goes into attempting to use the appropriate terminology. So I bring this this article in from the New York Times actually in 2022 to basically highlight this growing acknowledgement of the population who identifies as gender incongruent. And so we do know that the younger population is more and more identifying as either transgender or non-binary. And well, it's unlikely that there is such a large distinction between age ranges. Some of this is socially influenced as far as how open people feel they can express their gender identity. And so I think this is largely reflective of the acceptance and the acknowledgement of groups like you all who are providing this excellent care to these patient populations to be able to identify and appropriately bring to light what their true gender identity is. And truthfully, we all know individuals who are transgender, who are non-binary. The data is out there to support that this is not some small, these aren't one-off circumstances or situations. And we know that in the state of California, we're one of the highest concentrations of individuals who identify as transgender. So why the face? And I think that this is a really unique subject that carries some individualized benefits and also challenges for patients and individuals. This is just to highlight an article from the Metropolitan Museum in New York City. They had a display of art pieces that highlighted the face, the role that it plays in reflecting humanity and individual identity. And I think it really gets to the core issue that we're dealing with here, which is that the face is oftentimes the portal of expression to the outside world. And so it has sort of it serves a dual purpose. In self-identification, but in also expression to society around us. So that brings up the concept of gender expression. And this is an optical illusion that was created by a psychologist named Richard Russell, who essentially took two identical images, and all he did was alter the contrast between those two images. The image on the left with lighter contrast, the image on the right with darker contrast, and really demonstrates that much of what determines how society interprets gender and sex is based on lighting and contrast. And so I think this highlights in our transgender patient population the power of makeup. For example, when this was presented to a large audience, most people identified the image on the left as female or feminine, the image on the right as male or masculine, whereas in reality, it's the same image. And this is an individual by the name of Abigail Thornton. She is found on YouTube. She is a PhD in philosophy, and she's also a stage actress. And this is actually from her video, the same video about her coming out story. And she makes a transition on screen by altering her expression, and then talks a lot about what that transition means to her. And she does an excellent job, obviously creating a stark contrast, where she is able to even express her gender in a very hyper feminine way in some of her videos, and does a really neat job of demonstrating what can be accomplished with gender expression. So some might question, well, if we can accomplish so much with gender expression, what is the role of facial gender affirming surgery? And the concept of facial sexual dimorphism really stems from a long history, dating back to Greco-Roman time periods, and artistic interpretations of what at the time they called ideal masculine and feminine faces were. Many of you might be familiar with the concept of the golden ratio or the golden proportion that was found in nature, was adapted to the human face, and attempts were made to idealize or optimize what is the sort of hyper-feminized, hyper-masculinized face. And this has sort of been pervasive throughout art, throughout medicine, and really in an imperfect way has found its way into much of what we do in modern medicine and facial interpretation. This image is from a study that presented a number of faces to individuals in a blinded fashion, and found that absent of hairstyles, facial hair patterns, use of cosmetics or makeups or jewelry, any sort of accessories, there was a 96% ability to correctly identify sex or gender by an image of the face alone. And so there is truly something to a face that allows society and societal interpretation of that of gender from a facial structure. And so oftentimes this is what patients come to us and ask to modify or adapt so that they can more personally identify, more personally possess an outward appearance that identifies with their gender identity, both for themselves and for society. These facial proportions that were derived from this neoclassical canon are found in our, modern literature, as far as how we analyze the face. And in medical school and in training, we learn some of these proportions, which are obviously deeply flawed and imperfect in a number of ways, but sort of form the basis for how we approach the initial assessment of the face. And so I wanted to dive into that a little bit here, to sort of highlight some of the differences that we see between the masculine and the feminine face. And so one of the major divisions that we use when analyzing the face is to divide the face into horizontal thirds. And so starting with the upper third of the face, we think about, of course, the hairline, the forehead or the brow, as well as the eyebrow itself. And we can see here some of those highlighted differences that we will dive into a little bit further momentarily. Moving to the middle third, of course, we think about the nose, the eyes, the eyelids, as well as the cheeks. And then in the lower third of the face, we focus on the lips, the mandible, the jaw, and then, of course, the Adam's apple or the laryngeal prominence, which we'll discuss briefly as well. But harkening back to what Dr. Oosterhuis sort of pioneered here, and we have adopted into our practice as gender-affirming facial surgeons, most of these differences are derived from actual differences in the craniofacial skeleton. And so we do see that the male skull is sort of more rectangular in shape. It's wider, it's more pronounced, particularly along the orbital prominences, the mandibular angles, and the jaw. Whereas the female skeleton tends to have a less prominent brow, a greater projection of the cheeks or the zygomatic bone, and then a less prominent and shorter chin. And so studies have gone into highlighting the key differences in the craniofacial skeleton between the masculine and the feminine skeleton. And this is from our colleagues up at UCSF, who looked at a number of 3D facial scans and highlighted average differences in the prominence or the projection of different sites of the face. And of course, you can see here highlighted in blue that the projection of the brow, or that frontal prominence, is one of the major differentiators between the masculine and the feminine face or skeleton. Of course, the nose itself, as well as the cheeks, the jaw, and the mandible, all of these areas where we do see prominent differences in the craniofacial skeleton. To briefly dive into some of the data behind gender-affirming facial surgery, and before we really jump into some of the procedures that are done and how they're performed, I wanted to just sort of compile data, and I'm happy to provide these sources as well. These are certainly, this is not an exhaustive list, but I think it's an important list to highlight that we've really moved beyond a justification of this surgery to really an optimization of these surgeries. And that has done wonders, I think, for our patients who are seeking this type of care, to just lower one of the many barriers that they often have to overcome in order to accomplish care. We know, and we have shown, that gender-affirming facial surgery is safe, has a very low rate of morbidity. We know that it's associated with high patient satisfaction, reduced dysphoria, and increased quality of life. We've been able to demonstrate that gender-affirming facial surgery adequately addresses a number of psychosocial factors in patients, and is on par with other of the more sort of traditional gender-affirming surgeries that you might think about, including top and bottom surgery. We know that gender-affirming facial surgery plays a significant role, like we talked about, in changing public perception of gender. And even beyond that, it can really serve as a protective factor for many of the disparities that impact transgender or gender incongruent individuals, including mental health, substance abuse, targeted violence. All of these things go hand in hand with the outcomes that we have seen, the dramatic outcomes that we see with gender-affirming facial surgeries. Briefly touching on who is a candidate for surgery, and also the concept of medical necessity in gender-affirming facial surgery. Truthfully, there's no federal definition of medical necessity. A number of gender-affirming facial surgeons got together in 2002 and held the first International Facial Gender Symposium, and sort of wrote out the concept that any features that are affected by exposure to testosterone during puberty are adequate and appropriate targets for gender-affirming facial surgery, as well as secondary procedures to address the sequelae of those primary feminizing procedures. And this is really to address the fact that it's not just the bony procedures, but it is also soft tissue procedures as well that lead to the most desirable outcome for patients that are seeking gender-affirming facial surgeries. One of the things that we do run into with some amount of frequency is that insurance companies tend to lean towards the direction of procedures that primarily aim to address the effects of aging or the effects of gravity with time, as potentially being considered aesthetic or cosmetic. We have had a lot of success in appealing some of these decisions and ultimately providing the care to patients that they are seeking and that they deserve. And so I have to make a shout out to our patient financial advocates here, who do an excellent job of really advocating for our patients from an insurance coverage perspective in order to justify getting these procedures done in a timely fashion. Of course, the World Professional Association for Transgender Health has laid out a number of criteria for the standards of care in providing gender-affirming surgery. And here at Stanford, we aim to, at the very least, meet, if not exceed, these criteria when providing gender-affirming surgical care to patients. And in reality, there are no barriers that are set in stone to get into my clinic to see these patients for a conversation about what surgery entails and really to move forward with these procedures. A lot of what we're trying to do is make justifications to insurance companies to obtain authorization. To briefly comment on the role of hormone therapy in gender-affirming facial surgery, this is certainly, again, not exhaustive of the role here, but sort of how I think of it. I encourage my patients to understand that the face changes significantly under the influence of these gender-affirming hormone treatments. We know, and data has shown, that hormone treatments over time increase satisfaction with facial appearance in both trans women and trans men, exclusive of any sort of surgical intervention. This is one of the reasons, and I highlight this here, that you often hear about facial feminization surgery so much more than facial masculinization surgery, is that transgender men often accomplish or achieve many of the goals that they are seeking through the effective form of hormone therapy, which can have dramatic effect on facial hair growth, male patterned hairline, and also fatty changes that really can accomplish large changes in the masculinization of the face, and oftentimes lead to less strong desires to pursue gender-affirming facial surgery, although that is not to say that that desire does not exist out there, but is one of the many reasons that I think we often see more patients seeking facial feminization rather than facial masculinization surgery. I think that this is important to counsel patients, but certainly, again, not an obstacle to obtaining surgical intervention, that we have seen that hormone therapy beyond 2 years can have effects on some of the fatty or soft tissue changes that occur to the face. And so oftentimes, if patients are attempting to maximize the changes or at least reach a steady state of facial changes before pursuing surgery, that 2-year mark is a reasonable threshold to say that we feel confident that no major changes will be occurring beyond that point from their hormone therapy. And then just briefly to point this out so that you're equipped to tell your patients about this, but no studies have shown an increased risk of perioperative VTE when continuing hormone therapy during surgery. And so because of the other sort of adverse effects that can occur with discontinuing hormone therapy, I recommend that patients continue therapy through surgical interventions in my practice. So diving into sort of some of the major changes that we see with patients seeking gender-affirming facial surgery and the procedures that we can offer, I just wanted to highlight some of the different sort of artistic interpretations that exist out there and really demonstrate that there's some great educational materials and resources for patients available on the internet, both through Stanford as well as other sites. This is an illustration, and several of the other illustrations going forward are created by our excellent medical illustrationist, Chris Grollup, who I work with to create some of these illustrations for the purpose of patient education. I'd be happy to share these with any of you who might be interested, and they should also be available on the on some of the Stanford websites as well. I did want to put a quick disclaimer in here that there are some intraoperative surgical videos ahead, and so for any of you who might be disinterested in or feel uncomfortable with those types of videos, this part of the presentation does contain some of that type of information. The way that I've drawn, or I've sort of labeled this split face here, is that the left side of the screen attempts to highlight some of the facial masculinization procedures that we might do, whereas the right side of the screen highlights the facial feminization procedures that we will typically offer and explore. And much of what I'll talk about here going forward is going to explore those facial feminization procedures for many of the reasons that we've spoken about already. But really diving into the upper third of the face, we're looking at the hairline, oftentimes lowering the hairline to create a rounder hairline with less temporal recession that you might see with aging in masculine individuals. Oftentimes, this can incorporate hair transplant, which is one thing that I don't personally offer here at Stanford, but we do have resources in the community that we can direct patients towards. Frontal cranioplasty, we'll talk about in more depth in just a moment. That typically goes hand in hand with orbital rim contouring. And then, of course, brow lift and blepharoplasty are more of the soft tissue surgeries that aim to both open the eye and raise the brow in a fashion that feminizes the brow, which is typically placing it in a position that is above the orbital rim and in a more arched configuration. You'll see some examples of that in some of the patient examples that I have later in the talk. So really highlighting some of the bony work that we do in facial feminization and masculinization surgery. Frontal cranioplasty is the major bony surgery that we do in the upper third of the face. And there are various different ways to do this. And of course, the least invasive way involves simple contouring of the frontal bone. This illustration, I think, really nicely highlights how many individuals have a large aerated frontal sinus. And the frontal sinus is really the major obstacle to frontal prominence reduction, because of course, if we just simply drilled away bone of the brow, we would eventually enter into the frontal sinus and there would be nothing, no bone remaining to protect that critical space. And so in many of our patients, we are performing what we call a type 3 frontal cranioplasty. This is required in about 75 to 80% of patients seeking gender-affirming facial care, where we are actually creating a bone flap that we elevate off of the frontal sinus. We're contouring that bone flap and we're re-insetting the bone flap in a recessed fashion, which you can see in the third panel of this illustration at the top. Which demonstrates that we are actually insetting that frontal bone, the outer table of that frontal bone, while preserving the frontal sinus. And that's the one thing that's not illustrated there. It does look like the frontal sinus is missing in that third illustration. It's actually still there. It's just recessed. And so there are a variety of ways that we can access the frontal bone, but this is one of the more invasive procedures that we do. And so it involves typically large incisions along the hairline or higher up in the hairline to hide these incisions so that they're not sitting along visible sites on the forehead, such as what are illustrated in incision number 1 or 2 in this illustration, but typically incisions 5 and 6 are the ones that we're thinking about when it comes to this frontal contouring or frontal cranioplasty. So the next slide does show a significantly sped up video of that frontal cranioplasty and what it looks like intraoperatively. And so you can see that we have folded the skin of the forehead down to access the frontal bone. And we are actually going to elevate that bony flap, expose the frontal sinus in this region, drill down what we call the inner sinus septum to allow for recessed re-inset of that bony flap, put in place several plates and screws to hold that bone flap in place and create a more recessed appearance of that frontal prominence. And the next slide shows what this can look like on the table, both pre and post-operatively, to recess that frontal prominence and accomplish that bony change of the forehead, which is really dramatic in a number of patients. Getting into a little more of the nuance of the frontal sinus here from a surgical perspective, there's been a lot of work looking into, well, if we're impacting the frontal sinus, are patients going to have an increased risk of sinus-related symptoms? And there's significant data out there to demonstrate that no, patients actually do quite well from this perspective and don't have long-standing complications or issues from these procedures. And actually in the fourth panel of this image, for those of you who might be familiar with sinus imaging, The frontal sinus is still well aerated in this picture postoperatively, and we've really been able to accomplish a significant reduction of that frontal prominence while maintaining patency of the frontal sinus. And again, just like I emphasized previously, but complications are very rare and infrequently require reoperations for the sake of infection in these patients. This is a very well tolerated and well tested procedure. One of the things that you may encounter in these and other bony surgeries are the use of virtual cons to using these types of techniques. I do use them in my practice on occasion when I feel like it is called for, but this is really neat technology that allows us to use 3D renderings of patient imaging in order to be able to pre-plan surgical interventions, use templates like is highlighted in the top panel of this illustration on the right to create essentially guides for surgery in order to preserve safety, accomplish reliable outcomes, and have a very precise plan in place going into surgery to be able to accomplish what we're aiming to with these types of bony modifications. So moving on to the middle third of the face, typically we're talking about some form of cheek augmentation, which might include cheek implantation, otoplasty, which is at times indicated in individuals who have prominent ears. And then rhinoplasty is sort of the prominent feature of addressing the middle third of the face and is typically one of the driving forces behind patients seeking care sort of first and foremost in their mind and on their list of patient priorities. So again, a very sped up video of rhinoplasty and typically what it entails. Rhinoplasty is a combined soft tissue and bony surgery. This involves soft tissue dissection to expose the cartilaginous and bony structures of the nose, which live underneath the surface of the soft tissue of the nose. And typically what we are doing is we are modifying the cartilaginous and structures of the nose, and we're also using chisels and powered instrumentation to modify the bony structures of the nose as well, to create a nose that is either more masculinized or feminized. And to do that, we're typically either doing reductive rhinoplasty or reducing the prominence and the size of the nose for facial feminization surgery, or augmentation rhinoplasty to build up the nose in the case of facial masculinization surgery. And again, here an on the table result for a patient who is seeking a more feminized nose and all of the features that go along with that. And then finally, moving to the lower third of the face, from a soft tissue perspective, we are looking at augmentation of the lip, which can oftentimes include temporary or permanent fillers. We are talking about reduction of the mandible and thinking about narrowing of the jaw. And then, of course, the neck is a whole nother topic of conversation, which can include tightening of the skin of the neck, reducing fat of the neck, and then, of course, what we call chondrolaryngoplasty, or reduction or building up of the Adam's apple, depending on the desired outcome. I do need to make a plug here for my colleague in otolaryngology, Brian Nguyen, who is one of our esteemed laryngologists who does do gender-affirming voice surgery and also chondrolaryngoplasty. And so I do rely on him for most of my patients who are seeking augmentation to the Adam's apple, because that is a direct reflection of the larynx, and so it can have alterations can have impact on patients' vocal presentation and expression. And so he does provide that care, and very wonderfully so. And so if you haven't had the opportunity to meet or work with him, I would encourage you to seek him out as well. This video is highlighting some of the techniques that we use when augmenting the chin, and again demonstrating how we are attempting to both narrow and project the chin in this particular individual by creating actually osteotomies in the bone of the chin for the sake of narrowing and projection. And this is a two-piece genioplasty where you're seeing multiple osteotomies going into the chin, and we will see projection of that bony chin, and then actually fixation with plates and screws that allow for the chin to be slightly more prominent, slightly narrower, to sort of match the remaining craniofacial structure and the desired outcome of the chin itself. Similar procedures are done with the angle of the mandible in order to contour the jaw in a way that, in this case, is much more feminizing. This is an on-the-table result of a simple genioplasty that involves narrowing of the chin. And this is an illustration of actually shortening the height and narrowing the width of the chin. Also, three-dimensional rendering of what that genioplasty can look like. Also with mandibular angle reduction, no hardware in this case, but also just a reduction of the prominence and the flare of the angle of the mandible. So that was a whirlwind tour of many of the procedures that we offer for the sake of facial feminization, as well as facial masculinization. So what does this look like for patients? These are not necessarily my patients, but these are images that have been posted and are made publicly available online of what a preoperative marking might look like and what a post-operative dressing might look like. And you can see that these individuals look like they have been through the ringer, and that is very much the case if and when patients do have a full facial feminization procedure done at one time. It can involve a lot of surgery that can typically last from 8 to 10 to sometimes even 12 hours, depending on how involved and how invasive these procedures are, how much we're attempting to accomplish in a single setting. Just to provide a couple of patient examples to show what can be accomplished simply by bony and soft tissue modifications. This is a patient who had a frontal bone reduction, rhinoplasty, and genioplasty mandibular reduction. From the side view, this is another patient who has had frontal bone reduction, rhinoplasty, genioplasty, and a lip lift. And then this is one of my most recent patients who I just saw back in clinic last week, who is still in the process of healing from their procedure in which they had frontal bone reduction or frontal cranioplasty, a brow lift, rhinoplasty, lip augmentation, genioplasty, mandibular reduction. They're thrilled with their outcome and still healing. And so this is showing the dramatic result, I believe 6 months out now. We continue to advise and educate patients that they will continue to see subtle changes and improvements over the course of months, even to the point of 18 months to 2 years beyond surgery, as soft tissues continue to how I say to patients, shrink wrap down to the bony structures underneath the surface. So how do we prepare patients for gender-affirming facial surgery? These videos are demonstrating in cisgendered patients some of the changes that we counsel patients on as we are in the clinic, looking at some of the modifications that can be accomplished with surgery. And so these videos are just highlighting how we can really leverage technology to create three-dimensional images of patients and really model some of the surgical interventions that we can perform in the operating room as a goal-setting tool and a communication device to be able to reach a common outcome with patients as far as what they are looking to accomplish, what the limits of surgery can achieve, and how we can expect things to turn out once surgery is complete. And so a lot of what we do in preparation for gender-affirming facial surgery is to have open discussions about what patients' individual desired outcomes and expectations are. We have lots of candid conversations about existing limitations in where patients are starting from and where we can get them to, and whether or not that aligns with their individual goals. It's a shared decision-making process, and this is really highly individualized, which is influenced by, like I said, existing features and facial structures, patients' wishes, past experiences, perceptions, and related dysphoria based on individual features of their face. We do try to be somewhat subjective with our outcomes, even though I know that that's not always obviously a representation of the full picture, but I do like to use the modified gender Q scale and then a modified transgender appearance congruence scale that is modified to reflect the face specifically, in order to have at least some sort of subjective assessment of patients' uh, perception of their face, both pre and post-operatively, some of which can be used for internal assessment of outcomes and how good of a job we're doing for these patients and really getting them to accomplish the goals that they're looking to achieve. So what does this look like for patients from an individual perspective? We have all of these procedures that we can offer patients from the top of their head to the bottom of their neck. And this can happen in a variety of different orders. Some patients are seeking a single procedure, and we can accomplish that. It can take 10 to 12 hours, but in young, healthy individuals, that is a very achievable task, albeit a grueling one. Some patients are looking to sort of tackle these in more digestible bites. And so typically, we are looking at some form of division of labor that includes addressing maybe the upper third of the face, followed by the lower 2/3. But that can mean a variety of different things. And there are a variety of factors that go into determining when and how we address each individual subunit of the face, oftentimes which aligns with the patient's priorities for what they're looking to change the most, what grants them the most amount of dysphoria. Oftentimes patients have an idea of what they're looking to address in what order. And some of these adjunct procedures like otoplasty, like a facelift or a hair transplant, might then come in subsequent stages depending on, again, patient preference and priority, as well as feasibility. As we all know, patients come in with a wide breadth of knowledge, and these come from sites and sources that are online where patients are openly sharing a lot of their perceptions and experiences. And so you as a provider may have had yourself referenced on some of these types of sites, hopefully and ideally in a positive light. But really, these if you're not familiar with these types of forums, they're out there, they exist. They're a bastion of knowledge for individuals and patients. And patients come to us with a variety of levels of knowledge or individual perceptions of what gender-affirming facial surgery can accomplish, what resources are available to them, and what they would like to get out of these procedures. Many of my patients come in as a blank slate, and those are exciting experiences for me to be able to build their breadth of knowledge from the ground up and then encourage them to seek some of these other resources. And many come in knowing that this is this procedure that they want, and oftentimes it's then a negotiation with the patient to get to a point where we are on the same page as far as goals, what can be achieved, what can be accomplished, and limitations as well. There's a lot of work and research into what are the preferences of transgender and gender non-binary patients, because of course, not every patient comes in with the exact same desired outcome or the exact same goals for their surgery. Sort of going back to what I expressed at the beginning, we have a very flawed understanding of facial analysis and what determines what a masculinized or feminized face is. And not every patient or every individual is looking to achieve the hyper-masculinized or the hyper-feminized face. As a matter of fact, some patients are looking for something along that spectrum. So this was an interesting study that looked at the perceived femininity of patients and individuals, and found that that trans feminine individuals, as well as surgeons, tended towards selecting the most feminine appearing images, or the hyper-feminized images, as the most essentially attractive, which again is an ambiguous term, faces. And it really highlights that individuals, both cisgender and transgender, but also surgeons ourselves, have their preconceived biases that go towards what is considered a feminized face, what is considered an attractive face. And then, of course, trends in society also play a role in the greater overall perception of femininity and attractiveness. And so I think these are biases that we have to acknowledge and recognize and address in our goal setting as far as what we're looking to accomplish from the patient's perspective. Facial feminization surgery is a really individualized procedure, and there's really no consensus regarding best practices. And so these are often patient and provider-driven decisions. Like I said, there's a lot of shared decision-making that goes into these types of surgeries because they're big undertakings and they're very impactful, oftentimes also largely irreversible. We've shown that multi-staged surgeries are safe. There's no additive risk. And so if doing so, it's entirely appropriate for patients to seek out that type of care. Again, it's shared decision-making that goes into a lot of these decisions. Lastly, I just wanted to wrap up with a couple of comments on some of the larger ethical issues that surround gender-affirming facial surgery in particular. This is an excellent article put out by some of our colleagues from New York that address some of the major issues that go into societal construct, medical necessity, like we talked about, barriers to access, the concept of femininity and beauty. I think they do a really excellent, unbiased job of bringing in sort of both sides of a debate and a discussion over these moving targets as far as how we interpret them, how we address them, and how they play into individual patients' access and availability to care. I would highly recommend that you check out this article. It's a really interesting read. And very briefly to touch on, of course, mental health in gender-affirming facial surgery. As with the greater population at large, mental health issues do exist in our patient populations. There is ample data to demonstrate that transgender individuals do not uniformly carry a higher risk of mental illness, but this is something that comes into the calculus of if and when we operate on patients. We do know that pre-existing mental health conditions such as depression or bipolar disorder should not be used as a barrier to care for these individuals, but we do need to acknowledge and appropriately address these symptoms to make sure that they're well managed and well supported from a holistic care perspective in order to ensure that patients have the appropriate support systems in place to recover from a surgery that is large, that is temporarily debilitating, and that requires lots of post-operative care and recovery for all of our patients. We know that patients who receive these types of surgeries have major improvements in many psychosocial factors. And so again, just emphasizing the fact that these should not be barriers to care for patients, but that patients should be receiving appropriate and holistic care for all of their healthcare needs. One of the things that we do specifically encounter among facial plastic surgeons is the concept of body dysmorphic disorder. And in our cisgender patients, we have already a challenging time identifying which patients have defects or differences that are addressable and that are surgically correctable, versus slight or non-existent differences that are causing distress independent of what can be perceived or addressed. And so again, much of what goes into determining whether patients are appropriately supported and adequate candidates for surgery is a larger conversation around expectations and support that goes into the care that they have around them. And so again, I'm so thankful for the LGBTQ plus care community that we have here at Stanford, who does an excellent job of making sure that our patients have access to care, have support in the ways that they need in order to be excellent candidates for surgery, and to be educated and supported through those processes and procedures. So just to wrap things up, I wanted to make a plug for our gender-affirming facial plastic surgery site that is on the Stanford Healthcare web. I put a QR code in the upper right-hand corner for those of you who are interested in accessing it. That should get you straight to the URL. This includes a ton of really great information for patients as far as the risks involved with surgery, the expectations for recovery, what other resources are out there, what procedures are available to them. Please direct your patients to these sites. And I am also always happy to get input from yourself and your patients as far as what's helpful, what other information could be included. This is a living document that is ever expanding and growing. And then lastly, this is just my family I wanted to highlight. This is my little guy. He's a just over a year old now, and we're so thrilled to have him and be a family here in the Bay Area, and we feel so loved and supported by our community. And we're so thankful again for having me here at this talk. And that is it. I think I came in under the gun here, and so we may have a couple of questions, but Blaise, I just wanted to throw it back to you to see if you had any comments or anything else to disseminate before we start addressing some of the questions in the comment box here.
Well, thank you, Dr. Davis. This was incredible. And even though I did see a lot of this previously, it was great. I feel like we had more time to go in depth. I think last time we only had like 10 minutes or so.
Totally.
So this was really fantastic to get to spend more time and really go in depth to a lot of the advances and why this is so important to our patients, the difference that it makes. So I really appreciate you spending your time on that. You're getting a lot of glowing reviews already in the chat. And in fact, you have a good number of questions. And so I'd like to just spend our 4 minutes kind of covering these. And Lindsay, I'm happy to speak to them, but if you want to ask them, I see that you're able to be here still. Go right ahead.
Thank you, Dr. Davis. I really appreciate this. I just started getting into this community myself, and so I am eager to learn. So thank you for coming and speaking. One of my first questions, I know that we have a lot of gender affirming surgery options here at Stanford, and I would love to know sort of if there has been a process potentially of sort of having a one-stop shop or kind of a combining of a clinic or something or a program coming together. And I didn't know if that thought process has been discussed.
Yeah, absolutely. Thanks so much for that question, Lindsay. And I'll echo your sentiment as well. I'm new here at Stanford, and so I am still getting to know the community here, and everyone has been totally wonderful. And we really appreciate the care that is provided by our colleagues here. We do provide a full surgical suite of gender affirming surgeries, both facial surgeries as well as other body surgeries. And we have actually regular meetings, the LGBTQ plus surgical services, to grow and develop our collaboration among patients. Right now, it's done in a very piecemeal fashion. And some of our leadership, including Blaise as well as Benji, have played an integral role in sort of connecting us all so that we have sort of a direct line of communication. And it's really something that's in the works. We're working on developing a position that would include a surgical coordinator who could work with patients to make sure that they have all of the sort of resources needed in order to be able to make the correct decisions for themselves as far as what order do they pursue these procedures, who do they go to first, where do they meet, what locations are people at. I think it would be incredible if down the road we had some sort of multidisciplinary clinic that's at the same site and people could one-stop shop for all of the available options at once. It would be an information overload for them, but they would have the opportunity to sort of see and address everything all at once. We're not there yet, certainly, but there is nothing stopping us, and we will continue to work together as multidisciplinary services to grow in that direction. For now, we are all always happy and open to receive any sort of questions. I know that we're all willing to provide our cell phone numbers, contact information to be able to get patients into our clinics. And typically getting a patient to see one of us will sort of trigger a chain reaction where we shift people on to all of the rest of us, right? So my greatest or my most frequent referring providers are our other Stanford gender affirming surgeons who say, hey, I had this patient in my clinic. They're really interested in hearing what you have to offer, and let's get them plugged into your clinic. So once they're really under the Stanford umbrella, we have low barriers to sort of making that happen one to the other. Lindsay, I see your other questions here in the chat. Thanks so much for those. Are you good if I just move right on to the rest of these and kind of answer them in order here? Lindsay asked about issues with sinus headaches improving or worsening after craniofrontal surgery. So I did have one single source in my presentation that looked at what are called SNOT-22 scores. It's one of our standard metrics that we use for actually sinus-related symptoms. And pre and post-operatively in patients who have had frontal cranioplasty, we've been able to demonstrate that there is no statistically significant difference in sinus-related symptoms for these patients. Now, I will say that one of the things that I do see in a somewhat unpredictable fashion in patients, of course, is sort of prolonged neuropathies from any sort of surgical procedure. And, I did briefly touch on the fact that we're using incisions that are often hidden, but sometimes very, very large in these patients. And so patients will have large patches of numbness that will take a significant amount of time to resolve. I always tell my patients that nerves are always the last thing to recover in a surgery. And so sometimes that 12 to 18 months to 2 years of recovery can involve a prolonged period where patients have numbness or neuropathies or sensitivity related symptoms that we can treat with non-narcotic medications if needed. Oftentimes other sort of like massage-based therapies or non-medicinal therapies can be helpful as well. As far as chronic headaches, it's not something that I've experienced. It has been reported in the literature. It's one of the risks that we definitely advise our patients on. But I would say the overwhelming majority of patients do not have chronic or long-standing symptoms beyond that sort of recovery period or healing period. Does changing the chin affect the bite or jaw or have effect on eating? It largely does not. We are not shifting the occlusion like you might see in your patients who have had maxillomandibular advancement, say for overbites, underbites, or obstructive sleep apnea. We are actually just modifying the bony projections of the mandible and not the occlusion. And so there should be no change to the way that the teeth come together, which we call the occlusion, or their ability to chew or eat, although they may have obviously some temporary weakness or discomfort with chewing as they're recovering from surgery. And then what imaging is needed prior to doing these surgeries? Technically, no imaging is absolutely indicated or completely necessary. If we are looking to do virtual surgical planning, then we will obtain CT imaging that is done in sort of a specific way to get thin slices through the entire skull and neck, as well as what we call 0-degree gantry, where we can actually ensure that the patient has fiduciary points that are reproducible in the operating room so that we can have a high level of precision with the templates that we're using in the operating room. But I would say that as far as referring patients to my clinic, no imaging is necessary to get them in the door. And I won't necessarily order imaging on all of my patients. As far as how many we're doing at this point here at Stanford, I am not the only one that is doing facial gender affirming surgeries. Some of our colleagues in plastic surgery are also doing some of these surgeries. I would say that at this point, we are probably doing, on average, maybe a couple of these surgeries a month. My practice is certainly still growing. I'm seeing referrals at a rate that is greater than that. And so I will continue to grow that portion of my practice. I will say that one of the limiting factors is that In some of these full gender affirming surgeries, it requires an entire day of OR time. And OR time for surgeons is always our limiting factor as far as how many cases we can do at a given time. Some of these full facial gender affirming surgeries as well, I will keep patients overnight for observation if it has been a 10 or a 12-hour anesthetic, just to make sure that we're not sending them home at 8 o'clock at night when it's already dark out, and then having something, you know, a concern or a question or an issue where it's difficult to then get in touch with staff who have left for the day. And so that again is a limiting factor. What unit do they go to? That is a great question. Right now, we are these procedures are being done in the ambulatory surgery center, Lane Surgery Center here at Stanford, and then they are going to, in my practice, to our ENT units, which are the G and H units in the main in 300P. We have had some excellent instruction from our GRACE training team as well, and I should make a plug for them to any of my surgical colleagues who might be watching, to help get your support staff training on the use of appropriate pronouns, terminology, how to appropriately interact with patients, what to expect with patients, both pre and post operatively. That's really invaluable training as well for anyone who might interface with patients. And we've done that with our perioperative staff at Lane Surgery Center, as well as some of the floor nursing staff as well. Perfect. I think that's all I see in the chat. I'm certainly happy to receive questions by email. I think we've bumped up against our hour here. And so I'll let Blaze wrap things up if we have anything else left, but I want to thank everyone again for being here, for allowing me to speak. For those of you who are watching this asynchronously, please don't hesitate to reach out via email. I'm happy to provide my cell phone number as well, and I would love to help take care of any of your patients who might be interested in exploring this further.
Thank you, Dr. Davis. This was incredible. And I think you've got lots of praise coming your way. I'm excited to share this video with folks. And just want you to know, I'm so excited to hear the massive growth you've already seen. And it shows just how interested folks are in this care and how much of an unmet need there is in this area. So thanks for hitting the ground running. And thanks for spending our Pride LGBTQ plus health program grand rounds with us. You were a perfect topic and speaker for this event today.
Absolutely. Thank you so much again, Blaze, and happy Pride, everybody. Enjoy the weekend.
Thank you, Dr. Davis. Thank you, everyone, for being here. Goodbye.
Take care. Bye-bye.